Hello. You can make your way to your seats, please. Good evening, everyone. I'm going to make a housekeeping announcement before I begin because I have a script and I have no idea where else to put this particular announcement. So after this evening's festivities here, the Ohio Physical Therapy Association is hosting a free FREE event at the Gillig Winery, where there will be FREE wine and whatever heavy appetizers are. I think any appetizer is heavy if you believe in yourself, but, you know. So that's out of the way. Hello and welcome. I'm Dr. Ben Cooksey. I'm a faculty member in the DPT program here at UF, and it is my distinct pleasure to welcome you to the 2025 Research Forum and Euler Ceremony. We are so grateful that you could join us tonight to celebrate the hard work and dedication of our DPT students. Your presence here means a lot to them as it highlights the importance of their research and their journey in the program. As you've seen from their poster presentations, these students have poured time, energy, and passion into their projects. Each research project is completed under the guidance of a faculty advisor, and we are incredibly proud of their accomplishments. They say that evidence-based practice is a three-legged stool with equal parts provider experience, patient input, and the research literature that we generate with things like this. But that research literature prevents us from using the worst phrase in the English language, which is, we've always done it this way. So it's very, very important, and that cannot be understated. In addition to our students' work, we also have several faculty members here tonight who have contributed significantly to the field through their independent research, scholarly presentations, and even textbooks and chapters that have enriched the knowledge base in physical therapy. To our students, congratulations on the successful completion of your research. We'll now have 3 student groups presenting platform presentations of their research. In addition, we're thrilled to have one of our faculty members, Dr. Nicole Schrader, sharing her own research with us tonight. Each presentation will be roughly 10 minutes with a couple of minutes of question and answer to follow. So without further ado or discussion of appetizer types, I'd like to welcome the first group to the stage. Please welcome Braxton Fazzoni, Elizabeth Flynn, Daniel Miller, Madison Melsna, and Isaac Webb.
Awesome. Okay, so hi, my name's Elizabeth Flynn. Our faculty advisor for this presentation is Dr. Nicole Schrader, and the title of our presentation is The Relationship Between Rotational Strength, Ground Reaction Force in Female Adults with and Without Low Back Pain. So some background information on this topic and our purpose for the study. Ground reaction force is defined as a force that is equal in magnitude and opposite in direction to the force that the body exerts on the supporting surface through the foot. There has been previous studies that have demonstrated the importance of ground reactional force and hip strength in healthy individuals and possibilities of ground reaction force asymmetries after injury. Additionally, one study revealed that hip internal and external rotational strength correlated to postural control in females. However, to the knowledge of these researchers, there has been no studies that correlate ground reaction force, hip rotation strength, and low back pain in the female population. Therefore, the purpose of this study is to determine if there is a correlation between rotational hip strength and ground reaction force asymmetries in women with and without low back pain. This study has the potential to provide new insights into the treatment of female adults with low back pain.
I'm Madison. I'm going to be talking a little bit about the participants and then starting in on the methods. So with our participants, we were looking for healthy adult females between the ages of 18 and 65. They did or didn't have to have reports of low back pain in the last year. And then the exclusion criteria that we had for our participants was they couldn't currently be pregnant, and then they couldn't also have had a low back or lower extremity injury or surgery in the last 6 months. So with that being said, we were able to find 34 healthy female participants aging between 19 and 64 years old, with the average age being about 36 and a half years old. And then for reporting low back pain in the last year, it was actually split 50-50, so 17 of our participants reported low back pain in the last year, and the other 50% did not report low back pain. And then for the average height, it was about 5.5 feet tall for our participants, and then the average weight was about 159 pounds. And then with these two values, we were able to calculate the average BMI, which came out to just above 27, which is in the overweight category. And then we also took a look at hand dominance. So 32 of our participants were right hand dominant, and then 2 of our participants were left hand dominant. And then we also took a look at if our participants had previously given birth to a child or not. So again, it was a 50-50 split, with 17 of them never have given birth to a child before, and then the other 50% giving birth to at least one child. And then, so this is our first form of assessment we use. So this is manual muscle testing of bilateral hip internal and external rotation strength. So we conducted this in accordance to the Kendall text referenced here on the slide. So as you can see, for testing, the first one testing hip internal rotation strength, the stabilization hand goes on the inside of the knee, and then the hand applying the force goes on the outside of the knee, applying an internal force. And then vice versa for the hip external rotation strength, the stabilization hand goes on the outside of the knee, and then the hand applying the force goes on the inside of the ankle.
I'm Braxton, and I'll be taking you guys through some more of the methods and just into some of our analysis as well. So for our ground reaction force, we used a calibrated podium, and we would have our patients stand for 30 seconds to assess the ground reaction force, and the participant to assess load and symmetry and center of pressure. And then just for our analysis, we performed our analysis was performed via an SPSS software, and we also use a Pearson correlation to assess the ground reaction force, hip internal rotation strength, and ground reaction force, hip external rotation strength. We also ran a paired t-test to determine if there were any significant differences in hip strength and ground reaction force between those with and without lower back pain.
My name's Daniel, and I'm going to get us started on some of the results. So we ran a paired t-test to compare hip internal and external rotation strength between those with and without low back pain, and found that there was no significant difference. And then we also ran a paired t-test to compare ground reaction forces in between those with and without low back pain, and also found no significant difference in those variables.
And my name's Isaac. I'll be talking about the rest of the results and the conclusion. So for the correlation between hip strength and ground reaction force, our largest correlation was between right hip internal rotation strength and right ground reaction force and those who reported low back pain within the past year. Also, for those who reported low back pain within the past year, there's a medium correlation between right hip external rotation strength and right ground reaction force. And then on the left side of the body, there's a small correlation between left hip internal rotation strength and left ground reaction force, and then no correlation between left hip external rotation strength and left ground reaction force. On the right side of the table, for those who did not report low back pain within the past year, there was a medium correlation on the right side of the body between right hip internal and external rotation strength and right ground reaction force. And then on the left side of the body, there was a small correlation between left hip internal and external rotation strength and left ground reaction force. So in conclusion, significance was very difficult for us to find as our study utilized a smaller sample size. Therefore, no significant differences were seen between hip rotation strength and ground reaction force in females with and without low back pain. However, as we saw, there was a large correlation between right hip internal rotation strength and right ground reaction force in those with low back pain. So, weak right hip internal rotation strongly correlated with a smaller right ground reaction force, whereas stronger right hip internal rotation strongly correlated with a larger right ground reaction force. So, if you see a female with low back pain and she presents with weak right hip internal rotation, she may also present with a weight shift to the left and static standing, and vice versa. Previous studies revealed that 90% of females with low back pain had weak right hip internal rotation. Now, being able to identify these postural abnormalities, along with the statistics, could lead to a more effective physical therapy treatment and a quicker recovery for females with low back pain. Some additional considerations from the study is first, 94% of our study sample is right hand dominant. This could be an important factor when analyzing those larger correlations that we saw on the right side between right hip strength and right ground reaction force, as opposed to the smaller correlations we saw on the left side. Also, 70.6% of the participants with low back pain were postnatal. This could be due to the various anatomical changes that occur with the pregnancy, along with the postural or functional changes postnatal. For example, a mother may always stand with her child on the same hip. This will lead to increased ground reaction force through one limb, which could lead to asymmetries in the lower limb musculature, which could eventually lead to increased postnatal low back pain. So to wrap up, while these correlations are not causations, they're important factors to consider during a physical therapy treatment and evaluation of females with low back pain. And these are our references. Thank you.
Any questions for the group?
You determined that your patients were right hand dominant. Did you then assume they were right leg dominant? Is that the assumption? Okay. And when you did your manual muscle testing, was that data, were they all 5 out of 5, 4 out of 5? Were any 3 or 2s? Do you remember?
From what I remember, there's just a lot of variation. A lot of 3s, yeah, 3 pluses. There's some that were, from what I remember, up around 4 sometimes. So
No 5 out of 5?
I don't think so, no.
And this was a sample of convenience? Okay. Interesting. Thank you.
Thank you all very much. So the next group to share their work will include Mohsen Taher, Langston Kennedy, Josh Bluell, my spirit animal, Sean Gallagher, and Jeremy Baroner.
Does this come on? All right. All right. Hello, Ohio. My name is Sean Gallagher. Dr. Cooksey stole a little of my thunder. I was going to introduce the group, but he got that. Is everyone in here familiar with research or like research? I assume so. I knew you did. Most everyone probably employs evidence-based treatments in their normal daily practice, I would assume. So this is for you guys. But also I want to say thank you to everyone who came. Friends, family, faculty, staff, anyone who supported us. It's been a pretty long journey. I appreciate that. Our topic is something we chose because we were unable to find anything directly the same. So we picked changes in strength after mobilization or manipulation of the talar curl joint. We used the Maitland system for grading. Sorry to the Colton-Born guys out there. So we compared a grade 4 oscillatory mobilization to a thrust-based grade 5 mobilization. Those were our two techniques of choice. And the reason we oh man, sorry, we went with this, thank you, was when we were combing through the catacombs of research, we found that we were able to find certain topics that were similar but different. So we found biomechanical and functional changes in people after mobilization techniques were compared. We even found in a case study about thoracic manipulation, there were grip strength changes found afterwards. So this led us to design our research a little different. We wanted to know directly if it would improve or even if it would hinder it. So we just compared the two techniques. Oh, go hit that, Josh. We'll go. You want that up? Yeah, go ahead.
So I'm Langston. I want to speak a little bit about the purpose of the study. So as you heard, there's a lot of other studies that demonstrate the positive effects of joint mobilizations and manipulations. And even they have positive effects on perception of perceived function of the subjects involved. And it's widely believed that that is because of, it could be because of neural changes, whether that's improved muscle contraction or improving the mobility of a muscle to allow for, say, improved range of motion or improved strength. Or even just the mobilization or the manipulation improving the pain of the subject so they're allowed to move with better function. But we wanted to do a study to determine the effects of these manipulations and mobilizations on healthy subjects. And we'll talk a little bit later about the inclusion and exclusion criteria for our study. But we also categorized our data to determine that there's a difference between genders. And also our study was blinded. It was only single-blinded and not double-blinded, though, because we needed to be able to obtain the proper consent from our participants. And also a lot of our participants were PT students and faculty members, so they're already going to be familiar with the techniques that we're using. And, so that kind of made the double-blinding aspect difficult. But, yeah.
Hello, my name is Mohsin. So I'm just going to take you guys through the methods here. So we had somewhat of a small sample size. We were able to get 22 participants, 14 male and 8 female. We utilized a digital force gauge and we attached it to like an ankle cuff. So we were able to place that on the patient's ankle and have them perform the dorsiflexion maneuver to measure their strength force. What we did prior to each person's testing was we had them do 3 practice runs to make sure they were familiar with the way the system worked. And then we did 3 trials on each ankle to measure their total strength. After the 3 trials were completed, the individuals recording the data left the room, and our faculty director or our faculty advisor performed either a manipulation on one ankle and a mobilization on the other, which was chosen at random using a computer-generated randomizer. After that, we came back into the room, and they had each ankle strength was tested again to see if there was any changes. And again, as mentioned, it was a single-blinded study because we couldn't have the participants not sign a consent form. And essentially, this is somewhat of a pilot test because we didn't have a lot of participants, and we want to see if these changes can make if there's any notable changes in the future.
Hello, my name's Josh Blule. I'll be taking through the sort of statistical significance of our results. So considering a statistical significance for rejecting the null hypothesis is 0.05, the p-value. The first area we're going to look at is the combined results from both men and women. So looking at that, for mobilization, we had a p-value of 0.053, and for manipulation, 0.05. So both cases were pretty close to having statistical significance, but neither quite fell into that range that we were looking for. Looking at just mobilization, we broke that out into the two sexes. So for males, we saw 0.078. So, again, in that area, we're looking like we're getting close to some statistical significance, but weren't quite there. Women, we were off at 0.48, so that was not the case there. For just manipulation, we saw kind of the exact opposite. We saw a p-value of 0.36 for men, so not close to statistical significance, but for women, we saw 0.034. So, that's one of the kind of gets into like one of the weaker areas of our study is that we only had 22 participants. So, was it enough to like really show that there was a statistical significance? We're not sure, but it does kind of beg the question, was there actually a strength gain for females post manipulation? So, yeah.
All right. I'm Jeremy. I'm going to close this thing up. So for the discussion here, again, every study's got some strengths and some limitations. Ours has a few more limitations than strengths. But one of the strengths was that this was a single-blinded study. Again, double-blinded would kind of be ideal, but due to getting patient consent, then we had to kind of do single-blinded, and that was the best we could do. Again, inclusion-exclusion criteria, we wanted to make sure no one had any previous ankle injuries, make sure we're staying safe with everything. Another one of the strengths was the consistency of the testing. It was done in the same room, same table, same force gauge, and we had multiple people taking the measurements, but we all were trained to do it the same way, cued the same way to the subjects. Some of the limitations, biggest one was the sample size. We didn't have, again, 22 wasn't a huge sample size, so expanding on that in the future, there might be a little bit more power behind the data. We had a single cuff size that we used for everybody. We had a lot of different foot sizes, so that would be something in the future. Maybe we could vary based on shoe size. And then again, we had multiple individuals who were doing the measures. We were trained the same way, but people are different, so could be a little bit of variation there. And then the participants, you kind of get used to it. There's a little learning factor there, so maybe they improved later on. Maybe they changed their position, was another limitation. So biggest thing is that more people would kind of give this study a little bit more strength, and kind of fine-tuning some of the ways that we did things could improve things as well. And there's our references. That's it. Thank you.
Any questions?
In your, you were trying to get an audible response with the manipulation. Why were you going for that? As opposed to like you can do a grade 5, you wanted to hear it?
If possible. Then we did 3 chances to try to get a capitation just so that there was an objective measure of, okay, we got it there, and we can stop with capitation.
Oh, okay. But if you did 3 and you didn't, but you were doing a grade 5, yeah, okay, good, thank you. I was just curious as to why you had that listed.
They'll be mobilizing feet and ankles at the winery after the... And our last student-led group, or student-oriented group, if we could please welcome up here Anthony Fusco, Jared Leopard, Danilo Morlani, and Haley Kaufman.
Okay, our study is on the effects of cadence retraining and protocols on injury rates with a change with the randomized control over a 6-month follow-up, and this is a part of Dr. Huber's dissertation study. So our background, prior studies investigated the effects of cadence retraining on pain in runners with a noted reduction in pain, while others saw no correlation between a running cadence and running-related injury incidents. However, there's no conclusive evidence that cadence retraining can reduce running-related injuries, specifically among novice runners. Our purpose is to see if cadence retraining protocols using the principles of a motor learning theory and a pragmatic short-duration cadence retraining protocol will increase cadence in non-injured runners and reduce running-related injuries over a 6-month period compared to the control group. We aim to assess if either protocol results in greater effects in increasing cadence, and the study also aims to assess if either protocol reduces injury rates compared to the control group and see which has better retention of increased cadence. The rationale of our and significance of our study: running is a form of exercise, and ACSM has recommendations for adults to participate in moderate intensity to vigorous activity. And running is an important issue to address because millions of Americans begin running programs every year and then thus resulting in thousands of injuries. There are several important themes in our study that have either not been investigated, have been inconclusive results, or broad protocols, such as the relationship between cadence retraining and running-related injuries in non-injured participants, the effectiveness of cadence retraining protocols that are pragmatic versus grounded in motor learning principles, and the retention of cadence over time. So our study aims to address these gaps in literature so that injury rates among novice runners can be reduced and clinicians can have a protocol to help reduce running-related injuries. So our research questions: does a 6-week cadence retraining protocol with phased feedback and gradual increase in duration result in an increase in novice runners' cadence comparative to a control group at a 6-week, 3, 4, 5, and 6 months? Does a 2-week cadence retraining protocol result in an increase in novice runners' cadence compared to the control group at the specified times? Our third question: does a 6-week cadence retraining protocol with phased feedback and gradual increase in duration result in greater cadence strain compared to the 2-week cadence retraining protocol at the specified times? Our fourth question: do subjects retain an increase in cadence over the certain time with a 6-week protocol versus a 2-week protocol? And then our last question: does participation in either cadence retraining program correlate to a lower injury rates compared to the control group? And then our research hypothesis: both training groups will demonstrate increased cadence. There will be a greater increase in retention of cadence in the groups who receive the cadence protocol with phased feedback and a gradual increase in duration compared to the pragmatic 2-week protocol. And lastly, the lower injury occurrence will be found in the treatment groups compared to the control groups.
All right, so some important terms that we have to define before we really get into it. So we picked out 3, the first being novice runners, and these are defined as any individual with no former experience and never taken part in a running competition, that being like a 5K or a marathon. To further clarify, former experience is any formal coaching, participation in, or training competitively for a race. Running-related injuries are musculoskeletal pain in the lower extremities that cause a restriction on or stoppage of running for at least 7 days or 3 consecutive scheduled training sessions, or one that requires the runner to consult a physician or a healthcare professional regarding their pain. And then finally, the third one, cadence retraining. It's defined as any method of instruction or training that creates a change in the number of steps taken per minute while running. And then this is also referred to as gait retraining or step rate retraining. And so a little bit about our participants. Our inclusion criteria included everybody had to be over 18 years of age. They were all novice runners, and they had sustained no running-related injuries in the previous 6 months prior to starting the study. Exclusion criteria included a history of cardiovascular disease, cardiovascular signs or symptoms while exercising, and then certain conditions including diabetes, cancer, metabolic disease, renal disease, and cognitive impairments.
All right. So, going into our methodology, it was a randomized controlled trial with 6-month follow-up where we took data collection in gradual or over a period of time. So we utilized convenience sampling with stratified randomization, which for stratified randomization, we matched history of lower extremity injury with no lower extremity injury history. So what that looks like is we just looked at the chances of having a lower extremity injury versus a previous history of no lower extremity injury, and we kind of matched our population or our sample to that metric. So then we recruited 50 individuals, and then, like I was saying, we grouped them into no running-related injury history and running-related injury history, 34 and 16 respectively. And then we did 3 groups per stratum, so 2 intervention and then 1 control. So for our grouping, again, we had the control group, which they performed complete 3 30-minute runs per week. And then the first intervention group was a 6-week protocol with faded auditory feedback and gradual increase in training time. And then the second intervention group was a 2-week protocol with concurrent auditory feedback. So then here's our timeline. So we had an initial data collection period where we had them run the Cooper run test, which is a 12-minute running test. And then we started the interventions for the respective intervention groups. And then we did a 6-week follow-up where we also reperformed the Cooper run. And then we reassessed some other metrics. And then we did monthly follow-ups at 3 months to 6 months where we sent out a survey to record things like running-related injuries and adherence to the protocols. So then for our intervention groups, as you can see in the chart, we had the 2-week concurrent feedback with no fading, and then the 6-week faded feedback group. And then these are kind of the interventions that they performed each. So then going into what we actually collected, during the initial data collection, we received their demographics, and then we took a subjective related to previous running history and running-related injuries. We had them perform the Cooper run test, and we also educated them on how to use the Garmin watch. And then we took the cadence measurement via the Garmin watch during the Cooper run. And then cadence retraining was performed based on the groups that they were assigned to, so either the intervention 1 or intervention 2. For the 6-week follow-up, we also took another subjective form, and then we also had them reperform the Cooper run and cadence retesting. Like I kind of talked about, the monthly surveys were starting at month 3, and it related to running-related injuries and running compliance. And then due to the large volume of data, this presentation will only go up to the first 6 weeks of the study. The 3 to 6 month data we will continue to analyze in the future. So analysis, we put in the G-Power software to see what type of sample size we would need, and it told us that we needed about 36 subjects for the study, but we anticipated a large amount of attrition rate just with the period of running over or a decent period of time. So we kind of adjusted based on a previous study, and we ended up deciding that we needed about 50 subjects. So for data analysis, we initially attempted to use a linear regression, but we weren't able to make the models converge. So we actually had to switch into an ANCOVA, which I'll talk about in a second. But we performed ANOVA to make sure there was consistency among like demographical measures within the groups. And then we performed a repeated measures ANCOVA because we couldn't get the model to converge for the mixed effects linear regression. So for the covariates, we had the running time and the age. And then we also performed Bonferroni post hoc testing as appropriate and Cohen's D for effect size. For future, looking at the data that we have in the future, we did have a large attrition rate for the study, so we kind of want to go and use chi-squared to kind of see if there's any predictors or anything that could potentially be a bias for the amount of attrition that we had. So like I said, this presentation focuses on weeks 0 to 6.
All right, so getting into the results of our study, this slide is showing retention over time. So you can see at our initial, the baseline data point, we have 50 participants. And then after our initial 0 to 6 weeks of data collection, we lost 13 subjects, which is about 26% attrition. And it continues to curtail off throughout the remainder of the study. It's important to note that the attrition was not largely due to injury. We had 11 participants that ended up becoming injured throughout the study, which will be shown on a later slide, which is similar to other research, about 20 to 25% attrition due to injury. The rest was due to compliance, which looked like a number of different things. We deemed compliance or non-compliance as not hitting 4 out of the 6 initial training runs for the 2-week protocol, or 14 out of the 18 in the 6-week protocol. And then we asked them, as the study kind of went later, to run at least 2 times per week for 30 minutes. And some other participants left due to just not wanting to continue running 2 or 3 times a week for 30 minutes after 4, 5, 6 months. And then a couple of other people had other unrelated injuries and illnesses. And then this is another flow sheet that shows attrition. So you can see the percentages on the side. We weren't kidding. We had a lot of attrition. 82% by the end of the study, and it's interesting to note that each group started with a similar number of participants and ended with a similar number of participants. In this flow sheet, you can also see why they left the study at each time point. So the first grouping, where there's 6 across the row, that is at our 6-week follow-up. So you can see there the control group, the 2 intervention groups that were receiving the metronome feedback, why they left the study, and how many left the study at each time point. And then these were our injury rates. So again, only 11 participants were injured over the course of the study. Injuries were balanced between groups, 4, 4, and 3 between the different groups. And the majority of the injuries occurred initially, which again kind of makes sense. Novice runners starting a new running program, you tend to see more if you're going to have like overtraining or technique errors occur. It's going to occur when they're first starting the program as opposed to when they're more established. And then, so how do we control for external factors? So you might be thinking to yourself, well, these people are doing a lot of running. They probably just got more fit. Well, we did see a little bit of decreased resting systolic blood pressure, but it was not statistically significant. It had a p-value of 0.5, which, as the other group mentioned earlier, we're looking for less than 0.05 for significance. And then there was a slight increase in Cooper run distance, but again, it wasn't statistically significant, p-value of about 0.3. And these 2 graphs show kind of those changes. To the left is the blood pressure. The white circles will be your initial blood pressure, and then the black circles is the after 6 weeks. And then the right graph is the Cooper run distances, about a difference of 200 meters. So what this means is that changes in cadence were due to the retraining protocols, and it wasn't due to fitness-related adaptations. And then, is one cadence retraining protocol better than the other? So our control group, group 0, we did not see any change in their cadence as expected. We didn't give them any intervention. Our intervention group A, that is our 6-week protocol with the motor learning feedback, there was a significant change in their cadence, p-value of 0.009. And it's also important to note that there was a large effect size, which means that not only was there a change, but it was a meaningful change. It was a large change in their cadence. And the same can be true of group B, the 2-week pragmatic protocol. They also saw a significant change in their cadence, p-value of less than 0.001. So again, statistically significant, and they also had a large effect size of nearly 1, which means that it was a meaningful change. So that graph on the top, the one that goes straight across the circles, that is our control group. So you can see there's no change in their cadence. And then the 2 lines, yes, there are 2 lines there. Those are both of our intervention groups that had nearly the exact same change, which is something we did not expect. So that was exciting for us.
All right, so just to conclude our results, so in 6 weeks, both groups saw statistically significant and meaningful increases in cadence, so they both worked. The increases in cadence were also due to the retraining protocol and not just training effects, as Jared has just mentioned. This is demonstrated by the blood pressure and Cooper Run descriptive statistics. Also, it showed that the pragmatic protocol was just as effective at increasing cadence as the biomechanical one. And there were no statistical difference in running-related injuries between any groups. Okay. And so what can we do with all this information? Well, so these results can guide training protocols for novice runners when initiating running programs in the clinic or even just on their own. And because the pragmatic protocol is just as effective at increasing cadence, it can be utilized as an easier alternative compared to the motor learning-based one. And then neither protocol can be deemed safer in relation to running-related injury incidents, which conversely means that you will not have an increased risk depending on which protocol that you use. And this is the point that further research can definitely be done with a larger sample size, maybe do something to control attrition, maybe paying some people off, but hey, Jared's the one who brought it up. So this will be a point of further research. And here are references. Thank you.
Any questions?
How did you address the consistency with running surface?
So we didn't really have any control on that. We asked participants if we could have them to run not on a treadmill. We preferred if they were running over ground, so whether that be a track or sidewalks, road running, whatever that looked for them. But because it was convenience and we were just asking them to run, we were more concerned about the length of time that they were running and that they were tracking their runs with the watch so that we could see their cadence.
So were they instructed to run on the same surface all the time, or they could vary?
They could vary the surface they ran on. We just preferred not treadmill because the watches aren't quite as accurate on a treadmill.
Can you reiterate how you monitored their progress as far as they're doing it or not? Did you track them using any tracking device, et cetera?
So we had an app for it. We also sent surveys, and then the Garmin watch also tracked their runs. So we had them track their run anytime they started running and then end it when they stopped. So.
Good. And we will conclude our presentations for this portion of the evening with the hardest working woman in rehabilitation education, Dr. Nicole Schrader.
I paid him to say that. So my name is Nicole Schrader. I am a faculty here in the DPT program. Primarily my clinical practice and also my research focuses on the female population. Nothing against you gentlemen, but the research is already saturated with all the things that happen when we look at male participants. So I tend to focus on what happens in a female population, and this study, although it's a case study, which sometimes we think is like the lowest level of evidence, is done in a pregnant population, which is really hard to get IRB approval and really hard to do research in this population because of the risk associated with it. So typically when we have these high risk situations, we don't have a lot of participants signing up, and we don't have a lot of IRB folks that are like, yeah, go ahead and do that. So while we see it's a case report, it is pretty important in this field. So first, what are we going to talk about today? Main things we want to get out of this are we're going to talk about the benefits of exercise in a pregnant population, and then we're also going to look at what kind of fitness tests can we use and use safely. If you're taking the CEUs, here are the questions as a little putting this out there so you can kind of say, oh yeah, those are the questions that pertain to this topic, and you can kind of spy the answers, which one of the answers is in this slide where it says if pregnancy exercise is safe and important. The answer is true. Yes, it is. We have a lot of literature that says that it's safe, that it doesn't affect the mother or the developing fetus, and there are a ton of benefits, both physical and emotional mental, which is really, really important when we look at supporting this population. However, we don't have a lot of specific guidelines, and part of that is because of the risks that are associated. So when we have a high-risk population, the guidelines tend to be very general. Generally speaking, we have this guideline that says, oh, aim for about 30 minutes of activity. Activity could be doing laundry or cleaning your home, or it could be running a marathon. So we really don't have anything that says specifically, here's your dosage for intensity of exercise, what's safe in this population. And since we don't have the really kind of steadfast guidelines, we also don't really know if fitness can be maintained throughout a pregnancy. So that's the purpose of this study. We wanted to see if we have a pregnant female, can we maintain certain measures of fitness throughout the pregnancy and do so safely? So we're overall kind of looking at more like moderate intensity exercise, and a lot of the testing that I'm going to talk about is actually more sub-max level to help maintain safety, but we utilize that to try to then kind of figure out what their max values would be. So this case was a Caucasian female, 34 years old. They were physically active prior to pregnancy. This was their third pregnancy, and we did get PARMED-X approval. Any students remember what the PARMED-X is from Applied Phys? Yikes. Who taught Applied Phys to this cohort? Was that you, Dr. Huber? Ruh-roh. Anyway, the PARMED-X is a clinical questionnaire that we can use in our like at-risk populations. So it's a kind of a checklist that we can go through and say, is this patient safe to exercise? So the fact that we used the PARMED-X helped us get IRB approval because we had the OBGYN who certified this, who was very involved in the study, who filled out the PARMED-X, giving their approval, and that was really crucial to the IRB saying, yes, go ahead and do this research in a very at-risk population. Okay, so this is an overview of the fitness variables that we looked at. So we wanted to look at body fat percentage, at their cardiovascular fitness or their maximum oxygen uptake, strength, endurance, agility, and flexibility. Okay, body fat percentage to start with. So we did kind of an old-fashioned skin caliper method. It's old-fashioned, but it works. So a lot of clinical PTs will say sometimes what we know works, and in this case, this is true. So we used a caliper, and you pinch an area of tissue. There are 7 sites that we use that you can see on the bodies on the right there to figure out how much fat is there. And then you plug that into equation, and that gives you the body fat percentage. We also looked at using a submax treadmill test to help us figure out what the maximal oxygen uptake is. So basically how much oxygen your heart and lungs are bringing into your body. So it's a really good measure of cardiovascular fitness. And this test has 4 different stages. We change the incline of the treadmill and then increase the walking speed. You take heart rate at certain time points, and then that heart rate is used to figure out what your max oxygen uptake is. For muscle strength, we used a 10 rep max deadlift, so lifting the bar and plates from floor to waist height, doing that 10 times, which is roughly about 75% of a 1 rep max. So again, kind of sticking with more sub-max testing, safety of our pregnant participant. And then we used a 5 rep max hang clean. We used a hang clean so that it's partial range, moving from knee up through about clavicle height. And we used a 5 rep max, trying to stay on the sub-max range, and also anybody that's taken my CSCS class knows that when you're doing power exercises, you should stick with about 5 reps or less. Doing 10 reps of a clean, not a good idea. I had to add that in, right? Of course, okay. So that's how we looked at muscle strength. And then looking at muscle endurance, we used the ACSM guidelines for a push-up test. You can read the positioning up through there. Really, the only variation we had to make for this test was later on in pregnancy, because this test typically involves the chin hitting the floor. And we got to a point so far along in pregnancy that the belly just physically hit the floor before the chin. So we had to vary it that way. For agility, we use the hexagon test. Really simple, great clinical test where you make a hexagon on the floor, and then that athlete jumps in and out of the hexagon 3 times around, and you take the best of 2 trials. The only modification we had to make for this test was that the participant needed to use a little bit of a belly band later in pregnancy just to help support the belly. Flexibility, we use the ACSM sit and reach. A lot of clinicians are familiar with this. There is a sit and reach box, but we didn't want to take that to our data collection every single time. So we used a yardstick and a tape measure, which works just as well. You have the person exhale or breathe out and lean forward, and you're looking at the distance that they reach to assess their flexibility. Okay, so a lot of testing. What did we find? This is a pretty kind of simple graph to show that we did a paired t-test analysis. So we took all these variables actually pre-pregnancy, which is really great because this was a planned pregnancy. So a lot of times with pregnancy research, you don't always get to see what the pre-levels are because somebody doesn't want to do this maybe or sign up until they're already pregnant. So we had all of our pre-pregnancy variables that we could compare to. And when we look at what happened pre to post, we can see that body fat significantly went up. The VO2 max, or their cardiovascular fitness, did significantly drop. Muscle endurance did significantly decrease. The hexagon test for agility, it looks like it got better, but actually it took longer. So the agility decreased. And then the sit and reach increased, which we would expect to see in our pregnant population because relaxin hormone is flowing. So we're going to see a lot of ligamentous changes, which would make us think that, yes, that makes sense that flexibility is going to get more flexible throughout the pregnancy. Interestingly, though, the 10 rep max deadlift and the 5 rep max hang clean stayed the same. In fact, this participant said they felt stronger, which makes sense. Our CSCS folks, where are my students at, that as they keep going, they're going to build muscle strength. She wanted to do more. She wanted to lift more, but that's where the OBGYN, the physician overseeing it, kind of said, hey, the purpose of this study is not to see can they get stronger, it's only to see if they can maintain. So I'd rather you not keep increasing the weight. And she was deadlifting 85 pounds at 36, 38, 39 weeks pregnant. So we felt good about that. She felt good about that. And we didn't keep going primarily because OBGYN at that point said, let's not see if we can improve. Okay, so although we had some significant changes that maybe you would think are kind of negative, when we look and compare the values to our overall health and fitness values, what we'll see is that we actually, this pregnant person maintained good body fat all the way through, up through 39 weeks. Their VO2 max stayed in the, for some reason the color's not showing up on here, but the very good category, so they ended up with very good cardiovascular fitness. The push-up also was very good, and the hexagon test for agility was actually excellent. So this pregnant person was able to maintain essentially good to excellent fitness up throughout 39 weeks of pregnancy. Okay, so you may be thinking, yeah, that's great. This person was able to maintain some fitness throughout their pregnancy, but what else do we think about, or what else is going on? This pregnancy was carried to full term, so 39 weeks, 4 days, and their delivery was excellent health. The infant's APGAR score was 9, so pediatric students should get some head nods like, yeah, thumbs up, that's really good. So when we look at all these outcomes for both pregnant participant and the infant, we can safely say that females may be able to safely and successfully maintain that good to excellent fitness. So maybe do a little bit more than aim for 30 minutes of activity. So getting into that moderate intensity category for exercise throughout an entire pregnancy. Okay. I'll leave this QR code up here for a little bit for all of you that are probably going to want to check out all those references, right? Okay, thank you.
Can you hear me? Okay, perfect. Any questions for Dr. Schrader? Okay. All right. Hearing none, we are going to be transitioning to our Euler celebration. We are going to take about a 3 to 5 minute just break period as we get things set up here. And that should give some time if anybody came specifically just for Research Forum, potentially clinicians who want to leave, you can leave. If anybody wants to come up and get some of these front row or kind of middle seats that might be open, you could come get some seats as we transition. I see a lot of family coming in right now. So we'll take 3 to 5 minutes to make this transition and then we'll move on. Oh, if you are a clinician leaving, remember, Gillig, it's happening right now. Heavy appetizers and wine if you'd like to go.
Okay, so now what do I do?
Okay.